Abhi done it. Okay. Has everybody, can you hear me now? Is everybody okay with the audio now? Let me see. Is everybody okay? Yes, great. So we can start, and that is, see, don't worry about the Darrow-Yannet diagram. I've got a couple of messages about the Darrow-Yannet diagram. We've already spent 20-25 minutes on Darrow-Yannet diagram. It's not worthwhile spending more time on it. You have a look at the recorded video. In case you're not able to follow that, I'll put up another video, a special video only for Darrow-Yannet diagram, if that be the case. Okay? But don't worry too much about it. Once you sit down with your notes, see, what I want you to do now is that you have 6 days time till the next class. I want you to revise your notes thoroughly. I want you to do your notes. I want you to do the questions from the DQB. I'll also be putting up questions, videos, some important topics from whatever we do today in the coming days. In 6 days, I'll be putting up something every day so that you revise these 2 topics thoroughly. All right. Now, these are what we are doing today is something that we don't do very well in UG level. But there are a lot of questions which come from these first 2 chapters, which we are doing today in the PG entrance exam, whether it's NEET, whether it's AIMS, whether it's JIPMER. A lot of questions come from these 2 chapters. So that is why I'm spending a lot of time here. A lot of you feel कि ये तो 12th standard के concepts हैं, लेकिन 12th standard के concepts आप भूल भी तो गए हैं. So I need to remind you, and we need to apply those as far as physiology is concerned. Okay? So try and revise these notes when in these coming 6 days. Do your DQB, do all the questions from DQB, go through your CRS if you can. If you can't, that's fine. But definitely notes have to be revised again and again. And I'll put up little questions or something every day from these 2 chapters in the next 6 days. So that when you come back next Sunday, when I do CNS with you, then these first 2 chapters you would have done thoroughly. That is the idea. By the time we finish, you should be able to complete, your physiology should be absolutely complete. Okay? All right. अरे बेटा मैं कौन सा आपको आप बोल रहे हैं कि there are classes from morning to evening. मैं आपको कौन सा बोल रही हूँ कि पूरा दिन physiology करो, 2 घंटा करोगे, that is also enough. That is all I ask you, just 2 hours, and I'm sure you can spare those 2 hours. I know your schedule. 2 hours can easily be spared because you want to do at least 1 subject thoroughly. Okay? All right. CRS, if it's not possible, not a problem. CRS is not something which is mandatory. खोल के एक बार diagrams जरूर उसमें से देख लेना. Just go through the diagrams there. Sometimes, like for instance, CVS diagrams will be a little better there than what you make in class. So it's good to go through the diagrams there. Okay? Let's now go on to the next part. So we've done cell membrane, we've done the junctions. We've done what are tight junctions, what are gap junctions. Now the next thing is transport across the cell membrane. Right? Transport across the cell membrane. Let's discuss this. What is the transport across the cell membrane? Now, transport across the cell membrane, this is divided into 2 types. There is a passive transport and there is an active transport. Right? Passive transport and an active transport. Now, as far as passive is concerned, passive and active. Passive is a downhill transport. Passive is a downhill transport. Downhill transport means this is along an electrochemical gradient. Right? This is along an electrochemical gradient. That means it is along an electrical gradient and along a chemical gradient, concentration gradient. So this is along an electrochemical gradient. Okay? This is a downhill transport. Active transport is an uphill transport. That means this is against an electrochemical gradient. One major difference when I say downhill and uphill is downhill. Do I need any energy? No energy is required for passive transport, whereas in the case of an active transport, energy will be required. Energy will be required, right? This is passive and active. Now, what are the types of passive transport? Types of passive transport are, number one, simple diffusion. Simple diffusion is a passive transport. Simple diffusion. Then you have what is known as the facilitated diffusion. Facilitated diffusion. Number three is what is known as the non-ionic diffusion. Facilitated diffusion, non-ionic diffusion, and number four is osmosis. Active transport is further subdivided into primary active transport and a secondary active transport. So these are the different types of passive and active transport. Passive is along an electrochemical gradient, no energy is required. Active is against an electrochemical gradient, energy is required. Now we'll be doing all of these in detail. So let's have a look at the first one. First one is simple diffusion. Now, which are the substances which move by simple diffusion? Respiratory gases. Respiratory gases will move by simple diffusion. Oxygen, CO2, these will move by simple diffusion. All lipid-soluble substances. All lipid-soluble substances will move by simple diffusion. All lipid-soluble substances, these will move by simple diffusion. All lipid-soluble substances. What are the lipid-soluble substances? For example, alcohols. Alcohols will move by simple diffusion. All lipid-soluble substances such as lipid-soluble hormones, they will move by simple diffusion. All alcohols. Any lipid-soluble substance will move by hormones will move by simple diffusion, right? Lipid-soluble substances. Now, when you come to simple diffusion, Abhishek, osmosis is passive. No energy is required. No energy is required for osmosis. Now, as far as lipid-soluble hormone, like I said, all lipid-soluble substances will move by simple diffusion. Now, in simple diffusion, lipid-soluble hormones are steroids. Steroids will move by simple diffusion. So here you have what is known as the Fick's law of diffusion. Fick's law of diffusion. And what is this Fick's law of diffusion? Fick's law of diffusion states that G is equal to minus dA delta C by delta X. GA minus dA delta C by delta X. This is the Fick's law of diffusion. Fick's law of diffusion. And what is it? J? J is the net transport. J is net transport, right? D is the diffusion coefficient. Diffusion coefficient. Now, diffusion coefficient is different for different substances. Diffusion coefficient is different for different substances, right? D is the diffusion coefficient, and like I said, this is different for different substances. Diffusion coefficient is directly proportional to the lipid solubility of that substance. Directly proportional to lipid solubility, more lipid soluble the substance, more the diffusion coefficient, more will be the transport across the cell membrane. Then diffusion coefficient is inverse to the molecular diameter. More the diameter of a substance, less will be the diffusion coefficient, less will be the transport of that substance across the cell membrane. Then it is also inverse to the molecular weight of that substance. More the molecular weight, less the diffusion coefficient. But diffusion coefficient is inverse not just to the molecular weight, it is inverse to the square root of the molecular weight. It is inverse to the square root of the molecular weight, right? So diffusion coefficient will be different for different substances. Yes, directly proportional to the lipid solubility of that substance, inverse to the molecular diameter, inverse to the square root of the molecular weight. Now, out of these, you were asked a question, and that is, which is the most important characteristic which determines the movement of a substance across the cell membrane? Most important characteristic will become lipid solubility. Right? This is the most important characteristic which will determine the movement of a substance across the cell membrane. Yes? You were also asked another question which said that two equally lipid-soluble substances two equally lipid-soluble substances, if there are two equally lipid-soluble substances, which is the next important characteristic, next important factor? A, is it going to be the molecular diameter, or B, is it going to be the molecular weight, right? Two important questions here which have been asked earlier, and that is number one, if you have, what is the most important characteristic which determines the movement of a substance across the cell membrane? This is the this is the lipid solubility. And second question was two equally lipid soluble substances, which is the next important characteristic? This will be molecular diameter, not molecular weight, because please remember, transport is inverse to the square root of molecular weight, right? Now, this is D, diffusion coefficient. Let's look at the other factors which determine the movement of a substance across the cell membrane. And that is A. A is surface area. A is the surface area, right? Transport is directly proportional to the surface area. More the area available for transport, more will be the diffusion. Less the area, less the diffusion, right? A is the surface area. Then delta C. Delta C is the concentration gradient. Concentration gradient. More the gradient, more the rate of transport. J, transport is directly proportional to concentration gradient. More the gradient, more the rate of transport. What is delta X? Delta X is the thickness of membrane. This is the thickness of the membrane. More the thickness, less the transport. Remember, transport is inverse to the thickness. More the thickness of membrane, less the transport. So this is as far as your fixed law of diffusion is concerned. What is the fixed law of diffusion? This is J is equal to minus dA delta C by delta X. J is equal to minus dA delta C by delta X. I told you what is D. D is the diffusion coefficient, which is different for different substances. It is diffusion coefficient is directly proportional to lipid solubility, inverse to the molecular diameter, inverse to the square root of molecular weight. What is A? A is the surface area. What is delta C? Delta C is the concentration gradient. And what is delta X? Delta X is the thickness of the membrane. Thickness of the membrane. Now let's try and understand a few clinical parts over here, clinical application of what you've just done. And let's see what happens in a patient of emphysema. The minus sign, please understand, this minus sign over here does not have any mathematical significance. There is no mathematical significance to the minus sign. Minus sign over here is only giving you the direction of transport. This is giving you the direction of movement. This is trying to tell you that the movement is from higher to lower concentration. Higher to lower concentration. That is all that it tells you. There is no mathematical significance. It only tells you the direction of movement is from higher to lower concentration. That is the significance of the minus sign. Now, like I said, let's have a look at a couple of clinical parts here. Now, what happens in a patient of emphysema? What happens to a patient of emphysema? Now, in emphysema, now if you look at a normal alveolus, this is what a normal alveolus looks like, right? Normal alveolus looks like. What happens in a patient of emphysema? In a patient of emphysema, there is a breakdown of the alveolar walls. So this is what the alveolus starts looking like, right? There is a breakdown of the alveolar walls, right? Breakdown of the alveolar walls. And so what has happened to the total surface area? There is a decrease in the total surface area. If there is a decrease in the total surface area, this now decreases the diffusing capacity. This now decreases the diffusing capacity. Emphysema is the only obstructive lung disease. This is the only obstructive lung disease with a decrease in the diffusing capacity. Remember, diffusing capacity is not affected in obstructive lung disease. Diffusing capacity decreases in restrictive lung disease. But emphysema is the only obstructive lung disease with a decrease in diffusing capacity. Let's see another one. See what happens in pulmonary fibrosis. Pulmonary fibrosis. In pulmonary fibrosis, there is an increase in the thickness of the membrane. There is an increase in the thickness of the respiratory membrane, right? There is an increase in the thickness of the respiratory membrane. Pulmonary fibrosis, pulmonary edema. Pulmonary fibrosis, pulmonary edema, there is increase in the thickness of the respiratory membrane. And if there is an increase in the thickness of the respiratory membrane, there is a decrease in the diffusing capacity. Decrease in the diffusing capacity. I can't help it with the background noise. The upstairs people are getting some repairs done. And they are not there. They are not there. Their workers are there who will not willing to listen to me. So I can't help it. That background noise, after a little while, it will just go away. Please bear with it. Just close this door. It won't. It's right above. Yeah. All right. So there is a decrease. So these are the conditions where there is going to be a decrease in diffusing capacity. I told you J is inverse to the thickness. If the thickness increases, diffusing capacity decreases, right? This is there is a decrease in the diffusing capacity. One of them says, "Goli maar dijiye." Not a bad idea. So this is. So let's look at this question. Now there is a question here. It says, there is a membrane permeant substance. There is a membrane permeant substance. When membrane permeant substance, that means this is a lipid soluble substance. A membrane permeant substance, that means this is a lipid soluble substance. Yes, please look at this question very carefully. I want you to, let me see how many of you can answer this correctly. There is a lipid soluble substance, that means it is lipid soluble. Now, the lipid soluble substance, the intracellular concentration is 10 and the outside is 5, right? Intracellular concentration is 10 and outside is 5. The question says the intracellular concentration, the surface area and the thickness of membrane. The thickness of membrane, the surface area, intracellular concentration, surface area, thickness of membrane, these are doubled. The extracellular concentration remains unchanged. Extracellular concentration remains unchanged. What will happen to the rate of transport? Rate of transport, A. Will it become double? B. Will it become 3 times? C. Will it become half? D. Will it become 1/3? अब जिन ने बोला है कि गोली से मार दो और बम से उड़ा दो, मुझे पहले बताओ आंसर क्या है, नहीं तो मैं तुम्हें गोली से उड़ा दूंगी. जल्दी बोलो, जल्दी बोलो. कमेंट्स पास करने में तो नंबर 1, आंसर करने में Three times. Excellent. This is going to be 3 times. Let's try and understand this. Why is it going to be 3 times? Membrane permeant substance, that means it is a lipid soluble substance. Lipid soluble substance means it will move by simple diffusion. Intracellular concentration is 10 and outside is 5. So let's try and understand understand this question. Now, remember the formula. The formula was Fick's law of diffusion, is J is equal to minus dA delta C by delta X. J is equal to minus dA delta C by delta X. So if the surface area is doubled and thickness is doubled, one is in the numerator, the other is in the denominator. These will get cancelled. So ultimately, what is going to affect the rate of transport is going to be delta C, the concentration gradient. When inside is 10 and outside is 5, the concentration gradient is 5. If inside is doubled and outside is 5, now the concentration gradient is 15. When the gradient increases from 5 to 15, this is a 3 times increase in gradient. Remember that transport is directly proportional to the concentration gradient, right? So gradient is increased by 3 times, then the rate of transport will also increase by 3 times. Please understand, I'm deliberately asking you this question because I want you to be absolutely clear that it is not the concentration which is important. What is important is the concentration gradient, right? Concentration gradient is more important, not the concentration. The gradient has increased by 3 times. Therefore, the rate of transport will also increase by 3 times. Okay? So this is your simple diffusion. Fick's law of diffusion. J is equal to minus dA delta C by delta X. Let's have a look at the second type of passive transport. Second type of passive transport is facilitated diffusion, right? Facilitated diffusion. And what is facilitated diffusion? What happens in facilitated diffusion? Facilitated diffusion is also a passive transport. This is also a passive transport. No energy is required. Again, it goes from higher to lower concentration. So it follows an electrical gradient as well as a concentration gradient. Now, in facilitated diffusion, the characteristic feature is this is a carrier-mediated transport. There is a transport protein which is required. This is carrier-mediated. And if it is a carrier-mediated transport, there are some carrier-mediated transport. There are some important characteristics whenever a carrier protein is involved, and that is number 1, stereospecificity. What is stereospecificity? Stereospecificity. What is stereospecificity? The carrier protein is specific for a substance. Carrier protein is specific for a substance or a structurally similar substance. Right? Carrier protein is specific for a substance or a structurally similar substance. This is what is meant by stereospecificity, right? So the carrier protein is specific for a substance or a structurally similar substance. For example, the same GLUT. What is GLUT? GLUT is glucose transporter. The same GLUT can transport not only glucose, it can also transport a structurally similar substance which is galactose. Understood? So this is what is meant by stereospecificity. The carrier protein will be specific for a substance or a structurally similar substance. Second important characteristic is saturation kinetics. Saturation kinetics. That means a carrier protein will tend to get saturated. It tends to get saturated, and if it tends to get saturated, there is a Tm which is present. What is Tm? Tm is the transport maxima. Transport maxima. That means there is a maximum rate of transport which is present. There is a maximum rate of transport which is present. Right? So stereospecificity, that means this is a characteristic of a carrier-mediated transport. That means The protein can transport is specific for a substance or a structurally similar substance. Like, for instance, I gave you an example, GLUT. Glucose transporter can transport glucose as well as a structurally similar monosaccharide, which is galactose, right? Plus, number 2, there is going to be saturation kinetics. Whenever a carrier is involved, it tends to get saturated. So there is going to be a maximum rate of transport, or a transport maximum. Transport maximum. What do you mean by a transport maximum? So if you see this, if you see it graphically, if I have concentration gradient, if I have a concentration gradient on the x-axis, and if I have the rate of transport on the y-axis, more the gradient, more the rate of transport. This is seen in simple diffusion, right? More the gradient, more the rate of transport. This is going to be seen in simple diffusion, which we have already discussed, that J is directly proportional to the concentration gradient. So it's a linear relationship. More the gradient, more the rate of transport. But when I look at facilitated diffusion, now what happens is more the gradient, more the rate of transport. More the gradient, more the rate of transport, till it reaches a maximum. Till it reaches a maximum. This is seen in any carrier-mediated transport. This is seen in a carrier-mediated transport. More the gradient, more the rate of transport, till it reaches a maximum, and that is till it reaches what is known as TM, transport maximum, right? This is a carrier-mediated transport, right? Till it reaches more the gradient, more the rate of transport, till it reaches a maximum, that is transport maximum, right? So this is as far as your graphical difference between the simple diffusion and a carrier-mediated transport. TPT is transport, okay? Now, this is as far as your facilitated diffusion is concerned. Let's see what are the examples of facilitated diffusion. One I've already told you, GLUT, glucose transporters. GLUT or glucose transporters, right? Then another example of facilitated diffusion, urea transporters. Urea transporters. Urea, remember we have discussed it already, urea is a slowly permeating substance. It moves by passive transport, goes from higher to lower concentration, but it requires a carrier, and that carrier is known as urea transporter. Urea transporter. In the kidney, in the nephron, excellent question, Ruchika. Why slope more? Because it is facilitated. Slope is higher, in fact. It is facilitated by the carrier transport, right? It is, have you understood? It is, therefore the slope is more than in simple diffusion, till it reaches the transport maximum, of course. Now, in the nephron, the urea transporters which are present is UTA1, UTA2, UTA3, UTA4. These are subtypes of urea transporters. In the RBCs and in the vasa recta, you have UTB, right? So these are the different types of urea transporters. So glucose transporters, urea transporters. Then you also have amino acid transporters. These are proteins which are required for the transport of amino acids, right? Amino acid transporters. So these are examples of facilitated diffusion, right? Let's have a look at facilitated diffusion. I told you in facilitated diffusion, carrier proteins are involved, and whenever a carrier protein is involved, there are two important characteristics here: stereospecificity and saturation kinetics. What is stereospecificity? It is specific for a substance or a structurally similar substance. Like the same GLUT can transport glucose as well as galactose. Both are monosaccharides. So you've got one carrier protein for both glucose as well as galactose. Saturation kinetics, the carrier protein tends to get saturated. So there is a transport maxima which is present. There is a maximum rate of transport which is seen in all carrier-mediated transports. I told you about this graph. There is concentration gradient on the x-axis and rate of transport on the y-axis. More the gradient, more the rate of transport. This is seen in simple diffusion. More the gradient, more the rate of transport till it reaches a maximum, which is known as Tm. This is seen in all carrier-mediated transport. This is glucose transporters, urea transporters. Okay? All right. Mrinal Joshi, please remember, the rate of transport cannot be the same for all substances. Yes, it cannot be the same for all substances because these depend upon the carrier protein. Have you understood? Depend upon the carrier protein. But general, the facilitated diffusion is facilitated by the carrier protein, so the slope is more than that for simple diffusion. But of course, it can vary from substance to substance, isn't it? All right. Then the third type of passive diffusion is what is known as the non-ionic diffusion. Non-ionic diffusion. Let's see what is non-ionic diffusion. Non-ionic diffusion. Now, non-ionic diffusion is particularly seen in the collecting duct cells, right? Collecting duct cells. Collecting duct cells. Let's see what happens to the collecting duct cells. Now, this is a cross section of the collecting duct. These are the collecting duct cells, right? The Megha Majumdar. When I say urea is permeable, what is meant by that is it does not require energy. It is a passive transport. It moves from higher to lower concentration. The only important point being is it needs a carrier protein. That's all there is to it. Next is what is PM? PM is a transport maxima. What is transport maxima? It is a maximum rate of transport, which occurs because the carrier proteins tend to get saturated. Okay. The different types of urea transporters present in RBCs and vasa recta, the subtype is known as UTB. U standing for urea, T standing for transporter, B is a subtype. Okay. Yashaswani, you have a good question. Glucose, please understand what happens in diabetes mellitus. Diabetes mellitus, there is lack of peripheral uptake of glucose because of either deficiency of insulin or because of decrease in insulin sensitivity, as the case may be. The GLUT expression of GLUT is dependent on insulin there. That is the reason why. Yashaswani, I hope you've understood that. Okay. All right. Now, next, let's see. I will take the doubt later, but please also ask your friends to stop typing. When you are typing, you're also not paying attention to what is being taught. Therefore, you miss certain points. So it is a vicious circle which you are setting up for yourselves. Because you're typing, your attention is not on what I'm teaching, and therefore you're missing certain points and you continue your typing. So you have to decrease your typing here. right? It is disconcerting, distracting for all of us, right? Okay. Yeah, I would also suggest foundation and pre-foundation students, you will have a separate class. So don't worry too much. Take a break today. Sunday is meant for enjoying, right? Except for my regular batch. My regular batch needs to work, right? So the pre-foundation, foundation student can go on Netflix. Yes? Okay. All right. Now, as far as the collecting duct cells is concerned, just stop the typing. This is in the collecting duct cells. Now, collecting duct cells have the capacity to generate ammonia. Collecting duct cells can produce ammonia. Now, where does this ammonia come from? Where does this ammonia come from? There is breakdown of glutamine. There is breakdown of glutamine to form ammonia, and the enzyme which is responsible is glutaminase. Glutaminase is present in the collecting duct cells. This causes the breakdown of glutamine to form ammonia, right? See, very interesting. In the brain cells, ammonia is converted to glutamine. When I spoke about osmolytes and the need to increase the intracellular osmolality whenever there is a chronic hypernatremia, remember? So brain cells can produce glutamine from ammonia, but in the kidney, ammonia, remember, is toxic. So in the kidney, the reverse happens. Glutamine is broken down to form ammonia so that ammonia can be eliminated in the urine, right? So what happens is these collecting duct cells have the presence of an enzyme which is called glutaminase, which breaks down the glutamine to form ammonia. And now this ammonia will diffuse from the cells into the lumen. The lumen has the presence of H+, and ammonia will bind with the H+ to form ammonium ions. That means ammonia is moving across the cell membrane of the collecting duct cells in a non-ionic form, but it now binds with the H+ to become ammonium ion, right? So in other words, this is what is known as non-ionic diffusion of ammonia. Non-ionic. Ammonia is diffusing in a non-ionic form, but after diffusion, it becomes ionized. So what happens once it becomes ionized? What happens to ammonia concentration in the urine? Decreases. Ammonia will always be less in the lumen, because it is getting converted to ammonium ion. Have you understood? So ammonia will diffuse from cell to lumen, cell to lumen. It will continue to do that because ammonia in the lumen is reduces and it gets converted into ammonium ion, right? So please remember the secretion of ammonia. Secretion of ammonia occurs in the PCT and in the collecting duct, but non-ionic diffusion of ammonia occurs only in the collecting duct, not in the PCT. Can anyone answer why does it not happen in the PCT? What happens to ammonia why is there no non-ionic diffusion in the PCT, even though there is secretion of ammonia in the PCT? Can anybody think about it? What could be the reason? What could be the reason? Bolo, what could be the reason for that? The reason is the PCT has an excellent buffer which is present, and that buffer is bicarbonate. So whatever H+ is present in the PCT, it is buffered by the bicarbonate. So there is no H+ left to bind with ammonia in the PCT. So you do not see the formation of ammonium ion in the PCT. Excellent. Everybody has got this. Okay? So this is, you have secretion of ammonia in the PCT and in the collecting duct, but non-ionic diffusion of ammonia is only in the collecting duct. A gradient is maintained in the collecting duct, whereas you do not have a gradient in the PCT because there is no H plus in the PCT. Now, the next important point here is, what are the other examples? What are the examples of non-ionic diffusion? Like I told you, secretion of ammonia by the PCT cells, secretion of ammonia by the collecting duct cells. Secretion of ammonia by the collecting duct cells. Number 2, excretion of weak acids. Excretion of weak acids and weak bases. Excretion of weak acids and weak bases by the kidney. This is also by a non-ionic diffusion. Then absorption of weak acids. Absorption of weak acids. Weak acids such as salicylates. Absorption of weak acids such as salicylates, aspirin group of drugs, by the stomach. This can also be by non-ionic diffusion. Then absorption of bile acids. Absorption of bile acids. Bile acids are also weak acids. Cholic acid, ketodeoxycholic acids. Absorption of bile acids in the distal ileum. This is also by a non-ionic diffusion, right? Non-ionic diffusion. Please understand what you mean by a non-ionic diffusion. The substance will move across the cell membrane, but after moving across the cell membrane, it gets ionized. That is what is meant by a non-ion. It is moving in a non-ionic form, but after movement, it becomes ionized. Hence the term non-ionic diffusion. In the PCT, there is a secretion of ammonia, but no ionization of ammonia. The reason is because there is no free H+. H+ in the PCT is buffered by bicarbonate. Non-ionic diffusion is seen in the collecting duct. Ammonia moves from the cells into the lumen, but once it comes into the lumen, it gets ionized. So this is what you see, secretion of ammonia in the PCT is a simple diffusion, not a non-ionic diffusion. Have you understood? Secretion of ammonia in the PCT is simple. Higher to lower concentration, till concentration is equal on both sides. Here it is going to be non-ionic diffusion because after diffusing, it is getting ionized. Now, then the fourth type of passive transport is what is known as osmosis. Osmosis is the movement of water from a dilute solution to a concentrated solution. Dilute solution to a concentrated solution. This is the movement of water from an area of lower osmolality to an area of higher osmolality. From an area where water is more to an area where water is less across the cell membrane. This is known as osmosis. Right? So this is as far as your four types of passive transport. I've discussed four types of passive transport. The first one we said is the simple diffusion. We said simple diffusion, and what was important for simple diffusion was which are the substances which move by simple diffusion: respiratory gases and lipid-soluble substances, such as alcohols. Fixed law of diffusion, I said J is equal to minus dA delta C by delta X. D is diffusion coefficient, A is surface area, delta C is concentration gradient, delta X is thickness of membrane. J is directly proportional to diffusion coefficient, surface area, thickness of membrane, inverse to delta X. I gave you an example, emphysema. There is a decrease in the surface area, decrease in diffusing capacity. Fibrosis, edema, increase in thickness, decrease in diffusing capacity. I asked you a question, what happens in this particular question? I told you intracellular concentration is 10, outside is 5. The intracellular concentration, surface area, thickness of membrane are all doubled. Extracellular concentration remains at 10. What will happen to the rate of transport? Here we discussed the gradient increases by 3 times. Therefore, the rate of transport will also increase by 3 times. Facilitated diffusion. is the second type of passive transport, which is carrier mediated. Two important characteristics: stereospecificity and saturation kinetics. I showed you this graph. There is generally speaking, the rate of transport will be higher in a facilitated transport because, like I said, it is facilitated by the presence of a carrier protein. Yes, but but like I said, in a carrier-mediated transport, there is a transport maxima. Now, examples of carrier-mediated transport, I told you glucose transport and transporters, urea transporters, different types of urea transporters in the nephron, in the RBCs, in the vasa recta. Amino acid transporters. Then we spoke about non-ionic diffusion. Non-ionic diffusion seen in the collecting duct, where ammonia is transported in a non-ionic form, but after it enters the lumen, it gets ionized because it acquires the H+. Secretion of ammonia in the PCT is simple diffusion. There is no ionization of ammonia. But in the collecting duct, ammonia after diffusing becomes ionized. Examples of non-ionic diffusion: secretion of ammonia by the collecting duct cells, excretion of weak acids and weak bases, absorption of weak acids, and absorption of bile acids in distal ileum. Now, the next important point, this was passive transport. Now, next, let's have a look at the active transport. Let's see what is the active transport. Now, active transport, I told you, is an uphill transport. It is against an electrochemical gradient. It requires energy. There is a primary active and there is a secondary active transport. Primary and secondary active transport. Example of primary active transport is a sodium-potassium ATPase pump. Then you have the H plus K plus ATPase pump. H plus K plus ATPase pump. This is present in the parietal cells of the stomach. This is involved in the secretion of HCl. Na plus K plus H plus K plus ATPase pump. The number 3, another example of active transport, primary active transport, is SERCA. SERCA, sarcoplasmic endoplasmic reticulum, sarcoplasmic endoplasmic reticulum calcium pump. Sarcoplasmic endoplasmic reticulum calcium pump. This is present in the muscles. Muscles, sarcoplasmic reticulum have got the SERCA, which is a calcium pump. Sarcoplasmic endoplasmic reticulum calcium pump. Now, secondary active transport can be divided into two types of secondary active transport. Secondary active transport, this is, you could have a co-transport, or also known as a symport, or you could have a counter transport. Right? This is a counter transport, or also known as the antiport. Right? Secondary active co-transport and secondary active counter transport. Secondary active co-transport is a symport and secondary active counter-transport is an antiport, right? So this is active transport. Now, out of these, I'm first going to discuss the sodium-potassium ATPase. Sodium-potassium ATPase is ubiquitous. When I say ubiquitous, it means it is present in all the cells of the body. So you need to do this in detail. There are questions which are asked from sodium-potassium ATPase pump. So let's see this sodium-potassium ATPase pump. Now, sodium-potassium ATPase, like I said, is an example of primary active transport. Primary active transport. The first important point is, now, what does the sodium-potassium ATPase pump do? Now, for example, if this is the cell membrane, this is the carrier protein. When a carrier protein has got ATPase enzyme, I'm going to shade the carrier protein. So if a carrier protein does not have an ATPase enzyme, I will leave it unshaded. Shaded means ATPase is present. So sodium-potassium ATPase, it now pumps out 3 sodium. Sodium is moving from lower to higher concentration against a concentration gradient. It requires energy. Energy comes from the breakdown of ATP. And the same pump also pumps in to potassium. Again, potassium is moving from lower to higher concentration. Requires energy, comes from the breakdown of ATP. Right? 3 sodium move out of the cell, 2 potassium move into the cell. So my first question over here is, what is the coupling ratio? What is the coupling ratio? The coupling ratio for the sodium potassium pump, is it 3:2 or is it 2:3? Right? Now please remember, the coupling ratio will always be 3:2. Why is it going to be 3:2? Because the movement of sodium and potassium, this is a two-stage process. This is a two-stage process. Yes? Why? What do I mean by a two-stage process? The sodium potassium pump will first pump out 3 sodium, then bring in 2 potassium. It is not a simultaneous movement. It looks like it is simultaneous, but it is not simultaneous. First 3 sodium move out of the cell, then the 2 potassium come into the cell. So it is always 3:2 coupling ratio. That is why it is always known as a sodium potassium pump. You never call it a potassium sodium pump. Okay? So coupling ratio will always be 3:2. Second important point is, this is an electrogenic pump. Electrogenic pump. Yes, electrogenic pump. Electrogenic pump, why is it called electrogenic pump? Because 3 positive charges, 3 sodium are moving out of the cell, 2 potassium into the cell. 3 positive charges are moving out of the cell, 2 potassium charges are moving into the cell. So that means the sodium potassium ATPase pump, sodium potassium ATPase, it causes net loss of 1 positive charge. 3 positive charges are moving out of the cell, 2 positive charges are moving into the cell. So it causes net loss of 1 positive charge. And because of net loss of 1 positive charge, inside of the cell, inside becomes negative. Inside becomes negative with respect to outside. Inside of the cell is becoming negative with respect to outside. 3 positive charges have gone out of the cell, 2 positive charges have gone into the cell. So there is net loss of 1 positive charge, and inside will become negative with respect to outside. Now, if you remember, all cells have a resting membrane potential. And what is the resting membrane potential? Inside of the cell is negative with respect to outside. Right? Inside is negative with respect to outside. And sodium potassium pump is also doing the same thing. It is making the inside negative with respect to outside. So that means this sodium potassium pump must be contributing to resting membrane potential. So let us see, what is the contribution? How much is the contribution of the sodium potassium pump? Now, in cells where the resting membrane potential is minus 90 millivolts, in cells where the resting membrane potential is minus 90 millivolts, contribution of the sodium potassium ATPase, contribution of the sodium potassium pump is only minus 4 millivolts. Minus 4 millivolts. Remember, sodium potassium pump is making inside of the cell negative with respect to outside. But is this sodium potassium pump important in genesis of RNP, in contributing to RNP? No. It is contributing only minus 4 millivolts out of minus 90. That means resting membrane potential must be due to something else. And what is that something else? We'll discuss a little later. Okay, understood? But the point here is, sodium potassium pump, yes, it makes the inside negative with respect to outside. But Quantitatively, it is contributing only minus 4 millivolts out of minus 30, out of minus 90. So it is not important as far as a genesis of RMP is concerned, right? Now, the next important point here is this was a question which was asked, and that is, what is the most important function? What is the most important function of the sodium potassium ATPase pump? Which is the most important function of the sodium potassium ATPase pump? Is this genesis of RMP? This is genesis of RMP. Or B, is it going to be the cell volume regulation? Cell volume regulation. Genesis of RMP or cell volume regulation? Genesis of RMP, I've already proved it to you, it is not important. Therefore, by default, my best answer becomes cell volume regulation. Now, how does it help to maintain the cell volume? Let's try and understand that. How does it help to maintain the cell volume? Now, when I look at the cell, we know that sodium is in a higher concentration outside the cell and it is in a lower concentration inside the cell. Yes? Sodium is in a higher concentration outside, lower concentration inside the cell. Now, remember the cell membrane at rest. Cell membrane at rest is almost impermeable to sodium. It is almost impermeable to sodium. So when I say almost impermeable, that means the permeability is almost zero. But there will be a slight leakage. There is a leak of sodium from outside to inside the cells. Cell membrane at rest is almost impermeable, does not allow a free movement of sodium, but small amounts of sodium leaks from outside to inside the cell, outside to inside the cell. Remember, there is a concentration gradient for sodium. There is also an electrical gradient for sodium because inside you have more proteins which are negatively charged. There is a very strong electrochemical gradient for sodium. Electrical gradient because inside you have negatively charged proteins, and concentration gradient because sodium is in a lower concentration inside the cell. So there is a leakage of sodium. And remember, sodium is osmotically active. Sodium ke piche kya aayega? What is going to follow sodium? Water. So what will happen to the cell? The cell will begin to expand. The cell will begin to swell up. And if I do not control this, the cell will burst. How do we control this? This cell volume is going to be regulated by the sodium potassium ATPase pump. Because what is the sodium potassium ATPase pump doing? It pumps out 3 osmotically active particles and brings in 2 osmotically active particles, right? So sodium potassium ATPase pump. Sodium potassium ATPase pump causes net loss of. It causes net loss of 1 osmotically active particle. 1 osmotically active particle. Bhavit Kamlesh Agarwal, if you're finding it slow, then why don't you answer the queries now, which the other students are asking us? Answer them as well. It'll speed up things a little bit. Sodium potassium ATPase pump, there is net loss of 1 osmotically active particle, and this helps to maintain the cell volume. This helps to maintain the cell volume. right? This helps. Remember, sodium and potassium are both osmotically active. So the sodium potassium pump pumps out 3 osmotically active particles, brings in 2. Net loss of 1 osmotically active particle. So whatever water entered because of movement of sodium is now moving out of the cell. So cell volume is going to be maintained. Okay? So this helps to maintain the sodium. It helps to maintain the cell volume. Okay? So this is as far as your most important function, cell volume regulation. Second important point is the sodium potassium ATPase pump. It is a heterodimer. This is a heterodimer. What is hetero? Hetero means different. Dimer is there are 2 subunits. Which are the 2 subunits? This is alpha and beta. Alpha and beta. So sodium potassium pump, structurally it is a heterodimer, 2 subunits. So if I look at the 2 subunits here, remember the alpha is the larger one and beta is the smaller one. This is the beta subunit and this is the alpha subunit, which is the larger one, almost double the size of beta, right? So it is a heterodimer, alpha and beta. This is the cell membrane here. This is the ECF and this is the ICF, right? Now let us see what are the binding sites. What are the binding sites? The alpha subunit has got 3 binding sites on the inside. It is a heterodimer, 2 subunits alpha, beta, which are different from each other. Alpha is the larger one, beta is the smaller one. Alpha is almost double the size of beta. This is PR is protein. Pragati, Divya, mini proton nahi hai. Proton nahi, protein. So there are 3 binding sites. The 3 binding sites are, number 1, you have the sodium binding site. Number 2 is the ATP binding site. This is a very commonly asked PGI question, right? Which are the intracellular binding sites? Intracellular binding sites, there are 3 intracellular binding sites: sodium binding site, ATP binding site, and there is also a phosphorylation sites. Phosphorylation site. So there are 3 binding sites: sodium binding site, ATP binding site, and phosphorylation site. See, what is a phosphorylation site? Phosphorylation site, and that is, see, ATP is broken down by the enzyme to form by the enzyme ATPase to form ADP plus inorganic phosphorus plus energy. And this inorganic phosphorus goes to the phosphorylation site, right? Phosphorylation site, right? ATP is broken down by the enzyme ATPase to form ADP plus inorganic phosphorus plus energy. Inorganic phosphorus goes to the phosphorylation site. And what is the phosphorylation site? This is phosphorylation site. This is aspartate 376. Aspartate 376. This is amino acid aspartate at the 376th position. That is the phosphorylation site. So 3 binding sites on the inside: sodium binding site, ATP binding site, and phosphorylation site. Phosphorylation site is when the inorganic phosphorus is generated by the breakdown of ATP, it goes to the phosphorylation site. Right? Now, there are two sides towards the outside. Two sides towards the outside, and that is, there is a potassium binding site and number two, there is the ouabane binding site. Ouabane binding site. And what is ouabane? Ouabane digitalis is derived from ouabane. Yes, digitalis is derived from ouabane. Right? So these are three binding sites on the inside and two on the outside. Like I said, this is an important PGI question which has been asked. Which are the intracellular binding sites? Which are the extracellular binding sites? So this is as far as your the structure of the sodium potassium ATPase pump is concerned. Right? Sodium potassium ATPase pump. Next, let's have a look at which are the hormones which affect the sodium potassium ATPase. Hormones which affect the sodium potassium ATPase pump. Hormones which affect the sodium potassium ATPase pump. The first one is thyroid. Thyroid hormone will increase the number. It increases the number without affecting the activity. Right? Second is aldosterone. Aldosterone increases the number as well as increases the activity of the individual. Increases the total number of sodium potassium ATPases and it also increases the activity. Insulin. Insulin increases only the activity, isn't it? Insulin will increase the activity. Very common kind of a clinical situation. You have a patient of diabetic ketoacidosis. You give this patient IV insulin, and one of the most common complications is a hypokalemia. Why hypokalemia? Because there is like I said, increased activity of the sodium potassium ATPase pumps, and there is inward movement of potassium. Inward movement of potassium means the patient goes into hypokalemia, very commonly seen with insulin, right? When you give IV insulin, not normally, but when you give IV insulin. Number 4. Dopamine and atrial natriuretic peptide. Dopamine and atrial natriuretic peptide, there is a decrease. They decrease the activity of the sodium potassium pump. Again, this is a NEET 2017 question. Which of the following decreases the activity of the sodium potassium ATPase pumps? You were given this question and the answer was dopamine. Dopamine, right? So let us have a look once again at the sodium potassium ATPase pump, right? Let's see this. Sodium potassium ATPase pump, an example of active transport. When I say active transport, that means there is a carrier which is involved. There is a stereospecificity carrier which is involved, and it requires energy. Now, sodium potassium ATPase pump, this will transport 3 sodium out of the cell from lower to higher concentration, 2 potassium into the cell from lower to higher concentration. What is the coupling ratio? 3:2. It is an electrogenic pump. Why do we call it electrogenic pump? It causes movement of 3 positive charges out of the cell, 2 positive charges into the cell, causes net loss of 1 positive charge, and inside becomes negative with respect to outside. In other words, the sodium potassium pump creates a membrane surface charge. It creates a membrane surface charge, right? It makes the inside negative with respect to outside. 3 positive ions outside, 2 inside, so it creates a membrane surface charge. Next, I told you if it makes the inside negative with respect to outside, does it contribute to resting membrane potential? Yes, it does, but very little, only -4 out of -90. What is the most important function of the sodium potassium ATPase pump? It is going to be a cell volume regulation. Why cell volume regulation? Let's try and understand this. I told you, in the case of sodium, there is a very strong electrochemical gradient for sodium. Why very strong electrical gradient? Sodium is positively charged. Inside the cell, you have a high concentration of proteins, and proteins are negatively charged. So they tend to attract sodium. There is also a very high concentration gradient for sodium because outside sodium is very high, inside is very less. So very strong electrochemical gradient for sodium, but the cell membrane at rest is impermeable to sodium, almost impermeable to sodium. But when I say almost, that means there is a small amount of sodium which tends to leak. There is a leakage. And when sodium comes from outside to inside, water follows. Sodium के पीछे पीछे, water goes sodium के पीछे पीछे. जहां sodium गया, वहां पानी गया. So cell volume starts increasing. How does sodium potassium ATPase pump maintain the cell volume? It causes net loss of it causes movement of 3 osmotically active particles outside, 2 come inside. So net loss of 1 osmotically active particle, which helps to maintain the cell volume. स्ट्रक्चर क्या है सोडियम पोटेशियम एटीपेज पंप का? हेटेरोडाइमर है, 2 सब यूनिट्स है, अल्फा बीटा, अल्फा लार्जर वन. अल्फा हैज ऑल द बाइंडिंग साइट्स, 3 on the inside and 2 on the outside. Beta subunit is a glycosylated protein. Beta is a glycosylated protein. Beta is a glycosylated protein. It has got Beta subunit has got 3 extracellular glycosylation sites. It has got 3 extracellular, but there is no binding site on beta. All binding sites are on alpha. Yes, it is a glycosylated protein. It has got 3 extracellular glycosylation sites. Now, I said which are the hormones which affect the sodium potassium ATPase pump? I said thyroid will increase the number, aldosterone. Some people saying, what is aldo? This is aldosterone, which increases the number as well as the activity. Insulin will increase the activity. That is why when I give IV insulin, one of the commonest complications of IV insulin given to a patient of diabetic ketoacidosis is hypokalemia. Now, somebody says, why not a hypernatremia with IV insulin? Yes, because remember, insulin is causing the sodium potassium ATPase pump activity to increase. So 3 sodium are moving out of the cell and 2 potassium are moving into the cell. Hypokalemia, yes, but there is no significant hypernatremia. There is no significant hypernatremia. Yes? No significant hypernatremia. Why not a significant hypernatremia? Because you must remember how much is the normal sodium. Normal sodium is 140 millimoles per liter. In the ECF, sodium is very, very high, 140. Potassium, on the other hand, is very low, 3.5 to 5. So movement of sodium out of the cell will probably increase the sodium from 140 to 142 or 143. But potassium, the moment it comes down from, let's say, 5 to 2, that is a severe hypokalemia. So no significant hypernatremia because ECF sodium is, as it is very, very normal, ECF sodium is normally very, very high. So no significant hypernatremia. Dopamine and ANP are 2 hormones which decrease the pump activity. Okay. No, Nitesh, without a doubt, 3 binding sites intracellular are on all the binding sites are on alpha. Nitesh, all the binding sites are on alpha. Please be careful. 3 on the inside, 2 on the outside. Beta has no binding sites. Beta has only got the glycosylation sites. Okay. All right, so this is as far as your sodium potassium pump is concerned. Next, let's have a look at the secondary active transport. Let's see secondary active transport. Now, what is secondary active transport? Secondary active transport is known as secondary active transport. This is known as secondary because it is dependent on primary. There are two types of secondary active transport. You have a co-transport and you have a counter transport. Co-transport and a counter transport. Now let us see what happens in the Sriraj Alapati, as you asked, please remember for univalent ions, millimole and milliequivalent is the same. Sodium and potassium are univalent ions, so millimoles and equivalents, right, will be the same. Okay? Okay. Dopamine and ANP decrease the pump activity. They decrease the pump activity. Okay? Other primary active transport I will do as we go along. H plus K plus ATPase is involved in secretion of HCl. So when we do stomach, when we do parietal cells, we'll discuss this. Okay? Chalo. Now concentrate on secondary active transport. Now secondary active transport. Now, if you look at the PCT cell, now what happens in a PCT cell? PCT cell also has got microvilli. Yes, it has got microvilli. This is the basal side. It has got brush border. So on the basal side of these PCT cells, there is the presence of sodium potassium ATPase, right? Sodium potassium ATPase. So you've got sodium potassium ATPase on the basal side. So 3 sodium, 2 potassium, 3 sodium, 2 potassium. So what happens is activity of the sodium potassium ATPase, because of the activity of sodium potassium ATPase, there is an sodium potassium ATPase. It creates an electrochemical gradient. It creates an electrochemical gradient. It creates an electrochemical gradient for sodium. Why electrochemical gradient? Because remember, inside is becoming negative with respect to outside, and sodium is a positively charged ion. Concentration gradient. Why concentration gradient? Inside sodium is much less as compared to outside, right? So sodium potassium pump creates an electrochemical gradient for sodium. On the opposite side of the membrane, now sodium will move along its electrochemical gradient, which has been created by the sodium potassium ATPase. And this movement of sodium now provides the energy for active transport of some other substance. If the movement of the other substance is in the same direction as sodium, we call it a co-transport or a symport. And if the other substance moves in a direction opposite to the direction of sodium, this is known as the counter transport or an antiport. Co-transport or a symport and a counter transport or an antiport. Please listen to this once again. Sodium potassium ATPase creates an electrochemical gradient for sodium. On the opposite side, so basolateral membrane has got the sodium potassium ATPase pump, which creates an electrochemical gradient for sodium. On the opposite side of the membrane, now sodium will move along its electrochemical gradient, which has been created by the sodium potassium ATPase. And the movement of sodium now provides energy for active transport of some other substance. If the other substance moves in the same direction as sodium, co-transport. If it moves in a direction opposite to the direction of sodium, this is known as a counter-transport. The important point that you have to understand here is that if sodium potassium ATPase pump does not function, if this does not happen, neither can co-transport or counter-transport. Co and counter-transport depend on the activity of sodium potassium ATPase. If sodium potassium ATPase is not active, neither can co and counter-transport. That is why they're known as secondary, because they are dependent on primary. Right? So this is now let's see what are the examples of co and counter-transport. Let's try and see that. Co and counter-transport. Let's see examples of co-transport first. In the PCT of the kidney, you have what is known as sodium glucose co-transport. Sodium glucose co-transport, which is also known as SGLT, sodium glucose linked transport. Right? Here the movement of glucose is linked with the movement of sodium. And movement of sodium is because of activity of sodium potassium ATPase. Sodium glucose co-transport. Then you have a sodium amino acid co-transport. Sodium amino acid co-transport. Then in the PCT, you also have a sodium inorganic phosphorus co-transport. Right? PI is inorganic phosphorus. Inorganic phosphorus. Please remember, all these movements will be dependent on the activity of sodium potassium ATPase pumps on the basolateral membrane. Then in the thick ascending limb of the nephron, in the thick ascending limb, you have the presence of Na plus K plus 2Cl minus, Na plus K plus 2Cl minus co-transport. Na plus K plus 2Cl minus co-transport. You know there is a diuretic which can act on Na plus K plus 2Cl minus co-transport, and that is Lasix, loop diuretics. Loop diuretics. Right? What can act over here is Lasix group of drugs, furosemide, isn't it? In the PCT, which are the examples of co-transport, sodium glucose linked transport, which is also called SGLT. SGLT, sodium glucose linked transport, isn't it? You use then sodium amino acid co-transport, sodium inorganic phosphorus co-transport. There is a hormone which acts on sodium inorganic phosphorus co-transport, and that is parathormone. Isn't it? What is the action of parathormone? Parathormone increases plasma calcium levels but decreases phosphorus levels. How does it decrease phosphorus levels? Because it acts over here, sodium inorganic phosphorus co-transport in the PCT. Right? So this is as far as your PCT and the thick ascending limb is concerned. DCT, you have the Na plus Cl minus co-transport. Na plus Cl minus co-transport, a drug which acts on Na plus Cl minus co-transport, thiazides. Thiazides will act on Na plus Cl minus co-transport. Yes, Yash. All the co-transports and counter-transports will depend on the movement of sodium. They are linked with the movement of sodium, and movement of sodium is linked with activity of sodium potassium ATPase pump. That is why it's called secondary. Secondary transport is dependent on primary. If primary does not happen, secondary will not happen. DCT. Then let's see intestinal epithelial cells. Intestinal epithelial cells. Intestinal epithelial cells, you have a sodium glucose co-transport. Yes, SGLT inhibitors. Yes, absolutely true. Where you are, which is going to act here on the intestinal epithelial cells. SGLT inhibitors. Absolutely right. So you've got sodium glucose co-transport. You've got sodium amino acid co-transport. Distal ileum. Distal ileum has got sodium bile acid co-transport. These are examples of distal ileum. Thyroid cells. Thyroid cells. Thyroid cells have the presence of NIS. This is sodium iodide symport. Sodium iodide symport. Thyroid cells have got sodium iodide symport. Right? So these are examples of co-transport. Let's try and see them once again. I first gave you in the kidney, which are the ones which are present in the PCT, sodium glucose co-transport, SGLT, sodium amino acid co-transport, sodium inorganic phosphorus co-transport. I told you which is the hormone which acts on sodium inorganic phosphorus co-transport is parathormone. Parathormone increases urinary loss of phosphorus. Yes, it decreases plasma phosphorus levels, isn't it? Parathormone, it increases the urinary loss of inorganic phosphorus and therefore decreases the plasma inorganic phosphorus, isn't it? It decreases the plasma phosphorus levels. How does it increase the urinary loss? Because it inhibits the activity of sodium inorganic phosphorus co-transport in the PCT. In the DCT, in the thick ascending limb, you have sodium potassium 2Cl- co-transport. Lasix will act on this protein. It causes increased urinary loss of sodium, potassium, and chloride. It is a very effective diuretic. Along with loss of these electrolytes, there is also going to be loss of along with these electrolytes, there is loss of water. So it's a very important diuretic. Then in the DCT, you have a sodium chloride co-transport. Thiazides act on the sodium chloride co-transport. In the intestinal epithelial cells, you have sodium glucose co-transport and sodium amino acid co-transport. Distal ileum, sodium bile acid. Yes, there is also non-ionic diffusion, but you also have this mechanism. Right? They are both present in the distal ileum. Thyroid cells, sodium iodide symporter, right? Sodium iodide symporter, right? Now, sodium iodide symporter is also present in some other areas. Where are the areas where sodium iodide symporter is present? Let me just give that to you as well. Sodium iodide symporter, if you can see this here, it is present in the basolateral membrane of epithelial cells of the thyroid gland, of the salivary gland, thyroid gland, salivary gland, gestational breast, stomach, and the intestinal epithelial cells. These are the areas where you get sodium iodide symporter, which is an example of secondary active co-transport. So secondary active co-transport. ठीक है? Harshit Agarwal, if parathormone inhibits, Harshit Agarwal, parathormone inhibits sodium inorganic phosphorus co-transport. Inhibits it. Absorption phosphorus की कम करेगा, तो urinary loss उसका बढ़ेगा. Sodium inorganic phosphorus co-transport किस तरफ है? Lumen की तरफ. ठीक है अर्षित all right yes Sriraj Alapatti okay all right anything else parathormone कहां पर act करता है parathormone in the kidney acts at two places in the PCT it decreases phosphorus reabsorption. In the DCT, it increases calcium reabsorption. ठीक है? PCT में phosphorus की reabsorption को कम करता है और DCT में parathormone calcium की reabsorption को बढ़ाता है. Okay. So this is as far as your co-transport mechanisms are concerned. Okay? All right. Apical localization means towards the lumen. Apical means luminal side. Basal side and apical side. Okay? Okay. All right. Next, let's have a look at what are the examples of counter transport. What are the examples of counter transport? Let's see counter transport. Now, counter transport in the PCT cells, you have a sodium H plus. Sodium H plus counter transport, right? Sodium H plus counter transport. Then in the myocardial cells, myocardial cells, there is a sodium calcium counter transport, right? In the myocardial cells, there is a sodium calcium transport, right? Sodium calcium transport. Now see what happens in the myocardial cells is, this is a myocardial cell. Myocardial cell. Now you've got the sodium potassium ATPase pump, which pumps out 3 sodium and brings in 2 potassium, right? 3 sodium and brings in 2 potassium. Now you also have, now sodium will move along its electrochemical gradient. Sodium will move along its electrochemical gradient, but this gradient has been created by the activity of sodium potassium ATPase pump. And calcium will move out of the cell. This is a sodium calcium counter transport. Now, supposing I give this patient digitalis. Now we've discussed already, digitalis is derived from ouabain. And what is the action of digitalis? Remember, this is derived from ouabain. This will inhibit the activity of the sodium potassium ATPase pump, right? So if it inhibits the activity of sodium potassium ATPase pump, now sodium calcium antiport also cannot happen. Remember, I told you secondary is dependent on primary. If primary does not take place, secondary also cannot happen, right? So there is no secondary active transport. So what will happen to the intracellular calcium? Because of now there is going to be an increase in the intracellular calcium. And if there is an increase in the intracellular calcium, there is going to be an increase in the force of contraction of the heart. Digitalis is a positive, it's an inotrope. It increases force of contraction. Digitalis is used in patients of cardiac failure, right? And what is the mechanism of action? Digitalis will inhibit the sodium potassium ATPase pumps, which in turn will cause increase in intracellular calcium, and that means increase in the force of contraction. So positive inotropic action of digitalis. Remember, if primary active transport does not happen, neither can secondary. Yes? All right. Okay. Abhishek, you had got confused with the action of parathormone. Now I said, what is the action of parathormone on the kidney? Action of parathormone on the kidney. Action of parathormone on the kidney. This will be on the PCT and on the DCT. In PCT, it decreases inorganic phosphorus reabsorption. And on the DCT, it increases calcium reabsorption. Right? That is what I was trying to tell you. Okay? Okay. Okay. Digitalis, like I told you, digitalis, which is derived from ouabain, it acts on sodium potassium ATPase, and that in turn inhibits the sodium potassium ATPase. If sodium potassium ATPase is inhibited, sodium calcium antiport cannot happen. If sodium calcium antiport cannot happen, it will increase the intracellular calcium, which will increase the force of contraction. Okay. Yes, absolutely right. Shankara Rao, yes. Decreases inorganic phosphorus reabsorption, increases urinary loss of inorganic phosphorus. Okay. Okay, so this is your primary and secondary active transport. You have another mechanism of transport, and that is known as exocytosis and endocytosis. So we've done passive transport, we've done active transport. Passive, 4 types: simple diffusion, facilitated diffusion, non-ionic diffusion, osmosis. Active, primary and secondary. The next type of transport mechanism, which I'm going to do with you over here, is what is exocytosis and endocytosis. Let's see exocytosis and endocytosis. Now, what happens in exocytosis? Let's see this. In exocytosis, now if this is a cell and these are vesicles, and the contents of these vesicles have to be exocytosed. So what happens is the vesicles will now dock with the cell membrane, will bind with the cell membrane. After some time, the point where these have bound, this sort of dissolves. And what now happens is the vesicular membrane now becomes, will now become a part of the cell membrane, and the contents are now outside the cell. This is what happens in exocytosis. Raj, SGLT, this is just the basic concepts. When I've spoken, we've just introduced SGLT. When I come to kidney, when I come to GI tract, we'll be discussing which are the different types of SGLT present. Which are the SGLT in early PCT? Which is the SGLT in late PCT? What is the SGLT present? We do as we go along. Have patience, it's just the first class, it's just the introduction, just the basic concepts. So don't worry, don't be, just relax and learn what is being taught. Okay? All right. Now let's see what happens in exocytosis. Ye aspartate 376 kuch nahi hai beta, phosphorylation site hai. Sodium potassium pump ki alpha subunit. After all, alpha subunit kya hai? Protein hai. Protein is made of amino acids. Amino acids अलग-अलग तरह के होते हैं. जो amino acid aspartate है, which is on the 376th position, is the phosphorylation site. What does that mean? The inorganic phosphorus which is generated will bind with this phosphorylation site. Once it binds, there is a conformational change in the sodium potassium pump. इतना ही है, बस. ठीक है? Okay. All right, so this is exocytosis. Now, exocytosis, like I said, whenever the contents of a vesicle have to be exocytosed, the vesicle will dock with the cell membrane, and then the vesicular membrane becomes a part of the cell membrane, and the contents of the vesicle are now outside the cell. So what happens in exocytosis? There is an increased exocytosis will result in exocytosis increases in the total area of the cell membrane. exocytosis will result in an increase in the total area of the cell membrane. Why? Because the vesicular membrane becomes a part of the cell membrane. For exocytosis, you need calcium, you need ATP, and you need the docking proteins. You need the docking proteins. Right? You need the docking proteins, calcium, ATP, and the docking proteins. Now, what are the docking proteins? Docking proteins are syntaxin, which is also known as the T-snare protein. T-snare protein. Syntaxin is T-snare protein. Another docking protein is what is known as synaptobrevin. Synaptobrevin, or also known as the V-snare protein. T-snare protein and V-snare protein, right? This is syntaxin, synaptobrevin, and there is another docking protein which is called SNAP25. So this is what is required for exocytosis: calcium, ATP, and docking proteins. Docking proteins are syntaxin, synaptobrevin, and SNAP25. Now, one area where there is exocytosis taking place is going to be at the neuromuscular junction. At the neuromuscular junction, this is the motor neuron. This is the alpha motor neuron. Alpha motor neuron has got vesicles which contain the neurotransmitter, acetylcholine. Right? Alpha motor neuron will contain the neurotransmitter acetylcholine. And this is the muscle fiber. This is the muscle fiber. Yes. So there is exocytosis of acetylcholine from the alpha motor neuron. And present on the muscle fiber membrane are the acetylcholine receptors. Acetylcholine receptors. Yes. Acetylcholine receptors are present on the muscle fiber membrane. We will do it in detail in skeletal muscle. Yes. As of now, we need to know that there is exocytosis of acetylcholine at the neuromuscular junction. And like I said, what do you need for exocytosis? You need calcium, you need ATP, and you need docking proteins. Now, what happens in the case of botulinum toxin? In botulinum toxin will act at the neuromuscular junction, and this botulinum toxin will inactivate all these docking proteins. Botulinum toxin will inactivate all these docking proteins, all three of them: syntaxin, synaptobrevin, SNAP25. So if it inactivates these docking proteins, will there be any release of acetylcholine at the neuromuscular junction? No. So the kind of paralysis which is produced in botulinism, it produces a flaccid paralysis. It produces a flaccid paralysis, right? Botulinum toxin, there is no exocytosis. What is the site of action of botulinum toxin? Neuromuscular junction. No exocytosis of acetylcholine, so it produces a flaccid paralysis. Tetanus toxin produces a spastic paralysis. We'll do tetanus toxin, site of action, when I do CNS, right? Botulinum toxin, you know that this produces a flaccid paralysis, isn't it? Botox is used as an anti-aging, isn't it? Botox is, it produces a partial facial paralysis. Dilute botulinum toxin is injected, produces partial facial paralysis, and it clears, all the wrinkles get sort of ironed out, isn't it? Anna? If you look at Salman Khan, 30 years back, he looked just like what he does now. So This is, that is probably because of Botox. I'm sure he's using Botox, isn't it? All right, so there is anti-wrinkle because of Botox. So botulinum toxin will act on these docking proteins and produce a flaccid paralysis. Yes. Okay. Of course, Botox is used for hyperhidrosis. It is used for even migraine. So a lot of things. Yes. Okay. Now, there are two pathways of exocytosis. Two pathways of exocytosis. Yes. Now, what are these two pathways of exocytosis? And that is two pathways of exocytosis. There is a non-constitutive. There is a non-constitutive or a regulated pathway. Right? Non-constitutive or a regulated pathway. And the second one is called a constitutive pathway. So there is a non-constitutive and there is a constitutive pathway. Okay? Non-constitutive and a constitutive pathway. There are two pathways of exocytosis, non-constitutive or regulated pathway and a constitutive pathway. Now, first point is, non-constitutive is known as regulated. That does not mean that constitutive is unregulated. Even constitutive is regulated, but by convention. Non-constitutive is known as a regulated pathway. Okay? Now, what is non-constitutive pathway? In non-constitutive pathway, the synthesis of an enzyme, hormone, synthesis of an enzyme or a hormone or a neurotransmitter, synthesis of an enzyme or a hormone or a neurotransmitter. This is followed by processing. This is followed by processing. This is followed by storage, and then followed by release, right? Synthesis of enzyme, hormone, or a neurotransmitter. This is followed by processing, followed by storage, and followed by release. Yes, this is as far as your the non-constitutive or a regulated pathway is concerned, right? Now, what are the examples of non-constitutive pathway? The examples of non-constitutive pathway is secretion of insulin. Secretion of insulin by the beta cells of pancreas. Secretion of insulin by the beta cells of pancreas. Isn't it? Pehle kya banta hai? First you get a pre-pro-insulin, then pro-insulin, then insulin is stored and released as free insulin plus C-peptide. Isn't it? So there is a synthesis, there is a processing, there is a storage, and there is a release. Yes? Please remember the most important point being storage. Right? Synthesis, pre-pro-insulin, then processing, it is converted to pro-insulin, and then storage, and then a release as insulin plus C-peptide. Right? Then secretion of, let's say, glucagon. Secretion of glucagon by the alpha cells. Secretion of glucagon by the alpha cells. Then let's say secretion of, like I said, storage is most important. Secretion of enzymes by pancreatic acinar cells. Thank you, Vandana. Pancreatic acinar cells. Beta ji, I need a break more than you do. Just looking at your messages has already given me a headache. ना? बीच में topic रोक के कैसे break कर सकते हैं? Topic खत्म करने दो and then we'll take a break. What is the problem? Right? I need a break more than you do. अगर आप तंग हैं, परेशान हैं मुझसे, तो मैं भी आपसे परेशान हो रही हूँ. All right. Secretion of enzymes by the pancreatic acinar cells, right? So secretion of insulin by the beta cells, secretion of glucagon by the alpha cells, secretion of enzymes by pancreatic acinar cells. This is non-constitutive pathway. Secretion of acetylcholine at the neuromuscular junction. Yes. Secretion of, let's say, neurotransmitters such as serotonin by the Raffinmagnus nucleus cells. Okay? So these are your non-constitutive. Wherever there is a processing, wherever there is a storage and followed by a release, that is called a non-constitutive pathway. Please remember what is the most important as far as non-constitutive pathway is concerned: storage. Okay? Let's have a look at constitutive pathway. What happens in a constitutive pathway? Here, the synthesis is followed by a release. There is no storage, there is no processing. No processing, no storage. Right? This is followed by a release. What is the examples of a non-constitutive pathway? Constitutive pathway, like I said, there is no processing, there is no storage. No processing, no storage. Synthesis followed by a release. For example, secretion of immunoglobulins by the plasma cells. Secretion of immunoglobulins by the plasma cells. Right? Secretion of immunoglobulins by the plasma cells. Or let's say secretion of collagen. Collagen by the fibroblasts. Collagen by the fibroblast. There is formation of procollagen, but you must understand that there is no storage. Collagen, the moment it is synthesized, is going to be released. So it becomes a constitutive pathway. A very easy question you can get from here: which of the following is a constitutive pathway? Please remember, wherever there is processing, storage, it is non-constitutive. Wherever there is no processing, no storage, constitutive. Okay? So very easy to be able to pick out a very easy MCQ from here, and that is your what is non-constitutive and what is constitutive. Okay? जहां पर processing है, storage है, non-constitutive. जहां पर processing, storage नहीं है, that is constitutive. Now the next is, let's see endocytosis. Let's see endocytosis. Endocytosis. Okay? Now, some people saying, what about the hormones? See, you must understand, all water-soluble hormones are stored. Dopamine, catecholamines, people have said dopamine, catecholamines, these are all stored. So that is non-constitutive. Lipid-soluble hormones are not stored. So they come under constitutive pathway. Wherever there is a storage, dopamine, catecholamines, they are stored in vesicles. If you remember, dense core granules, isn't it? So that is non-constitutive. Lipid-soluble hormones will be constitutive. Now let's see what happens in endocytosis. Endocytosis, now for example, if this is the cell and this substance, has to be endocytosed. So what happens is, the cell will grow around it. Yes, the cell grows around it. The cell membrane will move around it. Then after some time, these two will sort of unite with each other. The vesicle which is formed will now detach from the cell membrane. Yes, it will detach from the cell membrane, and you now get, this is what will happen. Yes, so you get, this is endocytosis, right? This is endocytosis. So what has happened to the total area of the cell membrane? There is a decrease in the total area of cell membrane. There is a decrease in the total area of cell membrane. Why total area of cell membrane decreases? Because a part of the cell membrane becomes the vesicular membrane, right? Now, what do I need for endocytosis? What do I need for endocytosis? I need calcium, I need ATP, I need clathrin. Clathrin is receptor-mediated endocytosis. Receptor-mediated endocytosis. Again, this was a neat question which was asked, which is a protein which is required for receptor-mediated endocytosis, and that is clathrin. For endocytosis, I need calcium, I need ATP, I need clathrin. Clathrin is receptor-mediated endocytosis. Then also caveolin. Caveolin is present in endothelial cells. Caveolin is present in endothelial cells, and caveolin is required for absorption of nutrients. This is required for absorption of nutrients. Clathrin, caveolin, calcium, ATP, clathrin, caveolin, and also dynamin. Dynamin or pinchase. Dynamin or pinchase. Now, what is the role of dynamin or pinchase? Dynamin or pinchase will help in detaching the vesicle from the cell membrane. Right? It detaches the vesicle from the cell membrane. Right? So this is where the role of dynamin comes in. Once the vesicle is formed, then it has to be detached from the cell membrane, and this is with the help of dynamin. Dynamin will cause the detachment of the vesicle from the cell membrane. Okay? So the proteins required for endocytosis: clathrin, caveolin, dynamin. For exocytosis, syntaxin, synaptobrevin, SNAP25. For endocytosis, clathrin, caveolin, dynamin. This is required for the detachment of the cell membrane. So this is as far as your exocytosis, endocytosis. Please remember, exocytosis increases the total area of cell membrane. Endocytosis decreases the total area of cell membrane. Now, you also have what is known as transcytosis. Transcytosis. Transcytosis or cytopempsis. What is transcytosis or cytopempsis? Transcytosis or cytopempsis. Now, this is typically seen in a newborn. This is typically seen in the intestinal epithelial cell of a newborn. This is the intestinal epithelial cell of a newborn. Now, if you remember, a newborn is given colostrum, and colostrum is very rich in immunoglobulins. A newborn is given colostrum, very rich in immunoglobulins. Now, the intestinal epithelial cells, this is very rich in immunoglobulins. Still. Now, the intestinal epithelial cells of a newborn is unable to digest these immunoglobulins. So what happens is, the intact immunoglobulin molecule is absorbed by the process of endocytosis on the luminal side. The complete immunoglobulin molecule, which has not been broken down, is absorbed by endocytosis on the luminal side. And on the basal side, there is an exocytosis, so that the intact immunoglobulin molecule now enters the baby's blood. This is a very, very important route of passive immunity. Passive immunity in a newborn. Right? Passive immunity in a newborn. The complete immunoglobulin molecule is absorbed by endocytosis on the luminal side, and then by exocytosis, it enters into the baby's blood. This is what is known as transcytosis. Endocytosis on the luminal side, exocytosis on the basal side. Okay? This is as far as your right? This is as far as your transcytosis is concerned. So as far as transport across cell membrane is concerned, we have already covered passive, active, exocytosis, endocytosis, transcytosis. ठीक है, चलो. You can now take a 10-minute break. I come back on at 4:15. Okay? Now ask me questions. Sensible questions. Please. Bolo. Anything that you want to ask? Is thyroxine an example of endocytosis? अरे नहीं बेटा, मैंने बोला था जो non-constitutive exocytosis and constitutive exocytosis. Wherever there is no processing, we call it a constitutive exocytosis. So I said all lipid-soluble hormones are generally examples of constitutive. Thyroxine is a little different because there is a storage of thyroxine. Have you understood? Okay? All right. Gastric acid secretion, we will discuss it when I come to GI tract. Okay. See, pinocytosis, phagocytosis as examples of endocytosis. Phagocytosis is cell eating, pinocytosis is cell drinking. Isn't it? The examples of endocytosis. Okay. Today we'll be covering general physiology and nerve physiology. Yes. Yes. To break your fast, I'll be giving you 20 minutes break at 6:30. Okay? 6:30, 6:45. Fast break करने के लिए, what time do you want a break? 6:30 or 6:45? Chalo, I think most of you have got it. Now the questions are... Okay, chalo, take a 10-minute break, 6:15, we come back. Okay? All right.